Good morning. Good morning, and thanks to the organizing committee, TAN CSI 2019, for this opportunity. Mine is more of a diagnostic talk rather than a therapeutic talk, and so I've slightly changed the topic from strain-guided therapy in CAD to heart disease, so that I thought I'll cover a broader aspect of the application of this tool in the overall cardiology. So what is strain? Strain is a regional myocardial deformation, and what we mean by deformation is the myocardium undergoes changes in size and dimension. And when you actually measure this deformation in time, as the rate at which this deformation happens, it is called as a strain rate. The change in the dimension happens in 4 directions, namely longitudinal, circumferential, radial, and rotational. The values that can be measured can be a positive value or a negative value, and global longitudinal strain is the most common parameter that is used clinically, and an average value of -20 is considered to be normal, and a value anything less than -12 is considered to be grossly abnormal. So this is just a schematic representation of showing all the directions in which the rotation or the deformation takes place. And when the deformation takes place in the longitudinal direction, there will be shortening or lengthening of the fibers. Whereas when it happens in the circumferential or radial direction, then there will be thickening or thinning of the myocardial fibers. So what is speckle tracking is, when we quantify this strain or the strain rate, that is called as speckle tracking. So what we really do in speckle tracking is, it is just the normal grayscale imaging that we use in our routine echo. We capture images of the heart in the apical 4-chamber, 3-chamber, and 2-chamber views. And these images are fed to the computer, and a post-processing is done by the computer using standard algorithms. So what do we actually measure is speckles. What are speckles? These are naturally occurring acoustic shadows in the myocardium. And when we actually move these speckles, so we can actually measure the rate at which the speckles is traveling. So for ideally speaking, to measure the rate at which the speckle is traveling, we should have a frame rate between 50 to 70, so that we can actually track the speckles and see the change in the rate. So as I mentioned earlier, different vendors or different machines have come up with different criteria or set values, but any value which is about -20, the global longitudinal strain of -20 is considered to be normal, and anything less than -12 is considered to be grossly abnormal. So this is again a schematic representation of what we see as the bullseye view. So what we have is a 17-segment regional representation of the myocardium as advised by the ASC. And when there is a normal shortening of the myocardium, you will see a red color. But this color is not precise in meaning different machines can actually have different color coding. So when the shortening is abnormal, or when there is an abnormal lengthening, the color changes from the lowest of red to blue, and the values increases from a negative value to a positive value. So here actually you can see a different way of bullseye presentation, where when you see itself, it is very classical that you can actually find where the abnormality is. For instance, in this image you can see that in the inferior septum, inferior, and the posterior wall, it is blue, meaning that that segment of the myocardium is either akinetic or hypokinetic. Whereas in this picture we can see that the lateral, the inferior, and the posterior is red, whereas the entire other segment of the myocardium is pink, meaning the entire region is either hypokinetic. So what are the specific utilities of speckle tracking imaging in coronary artery disease? It can help us in diagnosing or detecting coronary artery disease. It can be used as an adjunct to bitumen stress echo. And in the context of myocardial infarction, it helps us in finding the size of the infarct, whether the affected ventricle will undergo remodeling in the future, which segment or which area needs reperfusion, and in predicting future events, as well as in assessing viability, as well as in prognosis. Yesterday we had a talk about all the latest guidelines and things published recently, and we saw that global longitudinal strain is an independent predictor of mortality in coronary artery disease, meaning reduced global longitudinal strain. So again, this is a schematic representation where you have an anterior wall MI. So straight away you can see that the anterior segment is blue or pink in color, whereas the rest of the LV is red in color, and the global longitudinal strain is reduced. At another picture where you have the inferior septum and the inferior wall affected, and you can also see that there is a dyssynchrony in this graphic pattern, and you can see a tight stenosis in the RC at the proximal segment. So what are the other applications of this speckle tracking imaging accepting for coronary artery disease? And this is where it is very interesting. See, we have been using M-mode modalities in assessing the EF of the LV, but we all know that the ejection fraction is not a very comprehensive assessment of the LV function, and for the LV and for the ejection fraction to become abnormal, it takes a lot of time, meaning when the LV is really diseased, that is when your ejection fraction becomes abnormal. So what is the usefulness of speckle tracking imaging or global longitudinal strain over EF is, it helps us in detecting subclinical abnormality in the LV function. So there are a various spectrum of cardiomyopathies where this can be applied, particularly in differentiating when you have a 2D echo and when you see an hypertrophic heart muscle. You don't know whether this is because of hypertension or true cardiomyopathy or because of athlete heart, and you put this speckle tracking imaging and clearly you can see the differentiation between the three, where in athlete heart the global longitudinal strain will be normal or supernormal, whereas in hypertrophic cardiomyopathy it will be totally grossly reduced involving all the segments of the myocardium, and in hypertensive heart disease you will have a regional variation of the involvement. The same principle is applied in all conditions where the myocardium is involved. Like examples are post-chemotherapy, post-heart transplantation, amyloidosis, sarcoidosis, and whatnot. The other specific indication is in assessing valvular heart disease, meaning assessing the LV function in valvular heart disease. And in fact, a lot of studies now suggest that, particularly in critical aortic stenosis where your LVEF is normal, there's no point in waiting for the LVEF to become abnormal. If your global longitudinal strain is abnormal or impaired, it is an indication for surgery, and patients do better post-operatively when the global longitudinal strain is normal as opposed to the abnormal. So here again a schematic representation. This is a very typical finding that we find in amyloidosis heart, where there is an apical sparing. So you can see the entire myocardium is affected, whereas the apex you have a normal strain pattern, and which is averages between -13 to -14. Whereas in the next picture you have an apical hypertrophic cardiomyopathy, where the remaining myocardium is normal, but the apex alone is affected. For those who are involved in perioperative assessment of patients before the surgery, I recommend reading this paper, because perioperative assessment of LV function is one difficult area which I encounter in my clinical practice. And sometimes patients come to you only for an echo assessment. They hardly even bring an ECG. And these patients will hide the symptoms or their past medical history because they're very eager to undergo the surgery. So they will not admit to you that they've had a heart attack or they have angina or whatever. So I am now becoming more confident in saying the LV is normal only when the global longitudinal strain is normal, because we all know that assessing the regional wall motion abnormality is very subjective, and it depends from one individual to another individual. And post-operatively, when they call us for having had any problem, it becomes difficult for us because we don't know what we saw previously. Although there is a comparison, we ourselves might go wrong. So the global longitudinal strain assessment gives a more objective assessment of the LV function, and it is highly recommended. So the areas where the longitudinal strain can be applied beyond LV is the RV, particularly in pulmonary hypertension, arrhythmogenic right ventricular hyperplasia, and pulmonary embolism. We saw that yesterday, and also in the left atrial strain. So what are the limitations of the spectral tracking imaging? First one is experience, which is really underestimated. Second one is the inter-vendor differences in the definition of the parameters as well as the cutoff for the global longitudinal strain. So to summarize, STI is applied in both coronary artery disease as well as in cardiomyopathies, and in the future it might gain more importance in RV function, assessing RV function and LA function. Thank you so much.